The first session is an informative session on data capture and analytics during COVID. And who better to talk to us about this than our keynote speaker, John Mattison, the Chief Medical Information Officer Emeritus of Kaiser Permanente. He believes that data plays a critical role in driving healthcare innovation. So with that very brief welcome and introduction, John, please go ahead.
So first of all, hello to all my informatics colleagues and friends in Canada and across the world. I'm going to be weaving together some of the biology of COVID and the COVID pandemic and how it's evolving with some of the analytic initiatives that we've undertaken. And I'm going to try and leave plenty of time for Q&A at the end. Next slide. So this is the proverbial pig and a python, and where are we now? I wish I could confidently say we're halfway done, but because this is a global pandemic and because vaccine availability is a problem in most of the world, and because we're all susceptible to the new variants emerging in other parts of the world, we don't know if we're 1/4 the way through, 3/4 the way through, but we need to redouble our efforts to accelerate beyond the current state. The most important thing is that we remain rationally vigilant in preventing these newer strains as much as possible through whatever physical distancing measures and masks that we can use until such time as we achieve something resembling herd immunity. Next slide, please. So this is the questionnaire that we created so that we would be able to have a standard format for data intake and triaging people, no matter how they entered the system. Everybody coming in with any complaint related to COVID filled out the same questionnaire, so we'd have that standard data set. Next slide, please. So this is a histogram of all of the visit types that we're using through our e-visit infrastructure. So we have a very robust infrastructure for people filling out forms, seeking advice on different kinds of conditions, whether it's a bladder infection or a skin rash or a sinus problem. And what you can see on this slide is that the vast majority of these now are related to COVID vaccinations, but the next two highest are both COVID disease-related conditions. Prior to COVID, we had comparable volumes, but obviously none of the COVID was there. So you can see how COVID has really displaced nearly everything else as a complaint for the purposes of this e-visit kind of context. Next slide, please. So this is our diagnostic order composer, where we had screening questions to decide who needed what kind of screening for COVID and influenza at each of these encounters. And this helps inform our dashboards and predict the trajectory of the demand on our services. So we have an idea, are things getting worse, are things getting better? And because there's such dramatic regional variations, we can do it by location, by medical center, across the program. Next slide, please. One of the earliest lessons of COVID was that a lot of hospitalized patients had blood clotting disorders of many kinds, deep venous thrombosis in the legs being one of the more common ones. But in addition, people with brain fog often have microemboli into the brain as the partial cause of that brain fog. And so the prevention of clotting was a key priority. So this best practice advisory showed up on anybody who was admitted to the hospital with COVID. Next slide, please. And one of the things that was real interesting is because we're a large scale system, we have 6 separate instances of our databases. They all talk to each other. It's a classical federated database model with publish and subscribe, but we had never really had the need for real-time reporting across every instance. So bringing all the data together from all 6 instances into one centralized source to create a single dashboard so that we could really make projections at a global scale was critical. So you can see across the top how many people are currently admitted, how many people are currently in the ICU, on a ventilator, emergency room volume, deaths, and total deaths nationally to date, and then broken down by medical center, and then a graph of the cumulative cases, and then daily hospital volumes, weekly trends and lab results, total lab results, and then daily hospital volumes by various locations in the hospital. So this dashboard has been instrumental in our ability to anticipate staffing needs and resources, PPE, and so forth across the program. It was a huge effort to get this in place. Familiarizing the people with this kind of near real-time dashboard was interesting because, as most of you know, when you do near real-time data, you're constantly getting updates that might change what was reported yesterday. So you might have 4,700 cases yesterday when you last looked, and then when you look at the updated real-time information, it may have risen to 4,800 or 4,900. That may seem like a very trivial thing for informatics folks like those on this call, but for clinicians who have never been accustomed to that kind of adjustment in real time, it was a bit confusing. So we actually had to back out some of the data points because they'd see them change and they lose confidence in the data, not really appreciating how real-time updates occur with a real-time dashboard. We also, it highlighted the need for us to be able to know where our ventilators are and what kind of demand there is on those ventilators and how to optimize the care because of the initial fears of shortages of ventilators. Next slide, please. So this is a graph of the vaccines administered to date, well over 1 million doses, almost 1 million people, and the various types of vaccines given with the totals, and then the total individuals vaccinated in each facility alongside some of the aggregate statistics. So these have been very helpful for us to identify where we're lagging behind with vaccinations and really put more effort in outreach and getting people in to get their shots. And I just read before this call started that President Biden has funded free Uber and Lyft rides to vaccine appointments for everybody in the country until July. So that's another method of getting shots in arms, which is so critical right now. One of the things that's worth highlighting is that we know that the vaccine provides long-term protection from serious disease, but the protection against getting infected at all is shorter term. So as the antibodies wane, you can still get infected, but underneath that are other immune mechanisms involving T cells that prevent us from getting severe disease. We also know that people who have already had COVID, when getting a vaccine, get about a 50-fold boost in their antibodies when they get the completed 2 doses of the vaccine. And so there's, the dramatic accomplishments of the biotech industry in producing these highly effective and really very safe vaccines. One of the things is that these new variants of concern that are emerging are being targeted by newer updates to the vaccine. So Moderna is almost done with a clinical trial of a vaccine targeted at the South African variant. And then Pfizer has announced that they'll be entering clinical trials soon in a vaccine that's updated for the Indian virus, which has 3 mutations of concern. And by all modeling and all experience so far, it looks like the Indian virus, which is pretty widespread globally, but not in large numbers yet, is the most contagious and perhaps the most lethal and perhaps most affecting of younger populations of any to date. And we've also just heard that one of the other mRNA vaccines that's coming to market has been delayed by a full quarter because of some supply chain issues in their raw materials. Next slide. So where are we headed? And this is a publication from Science done by some folks that are part of the COVAXIN Consortium, where I chair the clinical committee. And I'm just going to read it because it's so critical. We are currently faced with a question of how the severity of infection with severe acute respiratory COVID may change in the years ahead. Our analysis of the immunologic and epidemiologic data on endemic human coronaviruses show that infection blocking immunity wanes rapidly, but the disease reducing immunity is long lived. Our model, incorporating these components of immunity, recapitulates both the current severity of the infection and the benign nature of coronaviruses in general, suggesting that once the endemic phase is reached, that being when the pandemic's over and it just becomes another seasonal common cold, and primary exposures in childhood, SARS-CoV-2 may be no more virulent than the common cold. We predict a very different outcome for an emergent coronavirus, that is a variant, if it causes severe disease in children. So these results reinforce the importance of behavioral containment during the pandemic vaccine rollout, while prompting us to evaluate scenarios for continuing vaccination during the endemic phase. Translation: these variants, like the one in India, that are increasingly targeting and affecting younger people, have the threat of significantly prolonging how long the pandemic lasts before it becomes more of a seasonal endemic kind of cold virus, just like the 4 existing common cold coronaviruses are today. So again, just to highlight, while we're waiting for the vaccine rollouts, doing everything we can to prevent contagion is critical to suppress the emergence of these new variants, which could seriously prolong the duration of the pandemic. Next slide, please. So what are some of the critical priorities going forward? So the governor of our state of Florida literally passed a ban on vaccine passports, following the political messaging of his party. And yet the Norwegian cruise line, which has a pretty big business in Florida, is basically saying, well, then we're pulling out. If you don't allow us to use vaccine passports before we put people on board of a cruise ship, we're pulling out of Florida. So we have this tension between some regional public policy with the private sector and commercial enterprises. Next slide, please. So where are we with vaccine passports? So Australia was one of the first to announce that they're having a nationwide vaccine passport initiative, but other countries have jumped on board as well. Industries like the cruise ships, like the airlines, like the stadium events in the UK are following suit. The CDC aggregates individual data but does not release those individual data, and so they're not participating directly in the development of a vaccine passport. The World Health Organization, in contrast, has launched a global initiative. And when you think about, so we've got these national passport initiatives, we have these industry passport initiatives. What we really need is clear standards for interoperability between these various initiatives, so we can have a single source of truth for anyone traveling between any 2 countries, or within any country for that matter, depending upon their country of origin. So these 3 references that I put here are all related to the standard, the data standards behind the development, starting with HL7, and then there's an Argonaut group that sits on top of HL7, and the FHIR implementation, which most of you are familiar with, and then the World Health Organization initiative itself. Next slide, please. So the most critical data imperative for defeating COVID really is developing this vaccine passport so that we can restore normal travel, normal commerce, normal events, cruise ships, cruise lines, air travel, and large congregate events like rock concerts, musical concerts of all kinds, sporting events, and so forth. So The World Health Organization is open to public comment. This was issued on March 19th, and they're moving ahead very quickly in trying to standardize this. So we don't know whether we're halfway through this event, a quarter way through this event. And again, because these variants are changing the game, it's not over for any of us until it's over for all of us. So everything we can do to reduce the spread and the evolution of new variants is going to be critical. So I'm going to stop here and field any questions that anybody may have. Thank you so much.
Well, thank you, John, for a very informative presentation. And I'm assuming everybody can hear me okay. We have a question from the audience. Can you expand on learnings your group experienced while linking 6 data systems or instances together to produce near real-time data?
Yeah, the challenge, that seems very straightforward. You take the same data from the same fields, the same rows and tables and the same databases and aggregate them all into one. But when you're trying to do this in real time and make it truly near real time so that it's operationally actionable, there are challenges of making sure that your feeds, that the data entry and the data capture and the feeds are as near real time as possible. And probably the biggest issue I mentioned earlier is that when you have some asynchrony of reporting from one of those instances, you do see what should have been a fixed number for what happened yesterday continue to change as more data is entered locally. And so the more that the capture becomes automatic and the less manual intervention needed to ensure that all the data is captured in each of those instances was really an issue, and it remains an operational issue more than a data analytics or a database convergence issue. I hope that answered your question.
Well, I expect we'll find out if not. I was really intrigued that the clinicians had some lack of confidence as you went to real-time data. Has that been overcome? Did it take long to overcome? How did you get their confidence back?
Yeah, the team spent a lot of time educating people about how to use the information and how it and advising them that it would change as updates arrived. But that being said, clinicians who love to see solid, rock hard, reliable data, when they would see yesterday's data being updated today, would still get like this cognitive dissonance. And so what they did is they literally had to back out some of the data fields so that it wasn't as overwhelmingly undermining their confidence by virtue of what they thought were static numbers because they were in the past as they were being updated. So that was the biggest impediment. It did take a number of months to get through that, but it's very stable and embraced pretty uniformly right now in its current state.
So it sounds like they've embraced it and they're quite enthusiastic about this real-time delivery now.
It's really helped manage staffing models and projections of, are we on the uptick? Are we on the downtick? Do we need to get more people in tomorrow? Do we need to have less people come in tomorrow? Because everybody's exhausted. The frontline providers have really been overwhelmed for so long that there's a level of exhaustion that we don't want to bring people in unless we need them. And if we need them, we don't want to be understaffed either. So what they're doing is using these very deliberately and very consistently to be able to manage matching the supply with the demand, which does vary locally. So many of you are probably aware that during the massive spike that we had in Southern California, our Northern California partners were not experiencing the same level of spike because we had a variant that emerged in Southern California that hadn't yet spread to Northern California. So even within one state, we had significant regional variations. And so being able to project demand both globally and regionally, and at the level of an individual medical center has become very important. And I just want to highlight that I'm an emeritus status at Kaiser Permanente. So the team that's doing this work now is just doing a spectacular job, absolutely spectacular job.
Going on from that, who led this initiative in your organization? Was it the clinicians with the support of IT, or vice versa? And how did you link those two crucial groups together?
Yeah, that's a great question. So I was the first Chief Medical Information Officer for the Southern California region of Kaiser Permanente, and had the privilege of building an extraordinary team over several decades that put all this work together in advance of COVID, and then further evolved it during COVID. That team consists of frontline practicing physicians, full-time physician informaticists, multiple other non-physician nursing and pharmacy informaticists. We have regular meetings with people from operations, with the board of directors, with the directors of the medical centers, with the chiefs of each of the specialties. So what we already had in place was a very collaborative environment that involved nurses, doctors, pharmacists, schedulers across the entire organization, so that we didn't have people, in a silo developing solutions and then throwing it over the transom and saying, "How do you like it?" These were developed collaboratively between actual users and the data scientists and the analysts who put the data and the dashboards together. So it's a very rapid, agile cycle of development that involves players from both operations and from the informatics and analytics world.
I'm going to keep on going with questions until our organizers tell us that we've run out of time. But so the next one is, what kind of data cleansing or data validation do you use to ensure that your real data is accurate? And I'm getting the signal that we have maybe one more minute to answer this question.
Sure, and that's always a big question in data scrubbing and data quality, and garbage in, garbage out. So a lot of that in a closed system, pretty much a closed system like ours in terms of having mostly members, is pretty burned in, because the way we collect the data ensures that there's a high degree of fidelity in the data that we collect. Where we had larger issues is where we had people who were not members of Kaiser Permanente showing up in our emergency rooms and our urgent care clinics, where they had to be registered and a chart initiated and get them online with our online services. So there were issues with people who were not members not being familiar with the infrastructure, but that is something that through a period of effort has been addressed. So the data is pretty stable and reliable at this point in time.
This is such an amazing effort, John. I applaud what you've done at Kaiser Permanente and all of your expertise and knowledge that you bring to your organization and to us and others around the world. So thank you so much for a great session. I'm sorry to our audience that we didn't get a chance to answer all your questions. We could go on and on for some time, I'm sure. However, go ahead.
And that is that since I'm no longer in my role at Kaiser Permanente, there are others, Dr. Richard Chen, Dr. Nitin Damija, Dr. Dan Zizek, who really deserve the credit for this work. So that's the team that is doing this brilliant work, and all kudos go to them.
Well, I've been an admirer of your organization for a long time. So, but and you in particular, you've been a leader. So thank you so much for all that you've done.
Thank you so much, and have a great conference.
All right, thank you.